Hi, welcome to Heart Sounds and Murmurs. This topic is very confusing to students. There is a list of links for you to listen under the presentation on Blackboard. There are 4 locations to listen to heart sounds, and they correlate where the 4 heart valves can best be heard. 2 of them are located at the base of the heart. The base of the heart is the portion of the heart opposite the apex. It is superior and medially located. It forms the upper border of the heart, lies just below the second rib, and primarily involves the left atrium, part of the right atrium, and the proximal portions of the great vessels. The first listening point is the aortic valve, which can be heard best at the second right intercostal space near the sternal border. The pulmonic valve is best heard at the second left intercostal space near the sternal border. The tricuspid valve is best heard at the lower left sternal border at approximately the 4th to 5th intercostal space. And the mitral valve is best heard at the apex, which is normally located at the 5th intercostal space at the midclavicular line. To hear the sounds, the diaphragm is used for the high-pitched sounds and the bell for the low-pitched sounds. The sequence of auscultation should be from the aortic area to the pulmonic area to the tricuspid area to the mitral area. I always have to think about this and use the mnemonic, all physicians take money, to remember to which valve I am listening. To accentuate sounds, additional posturing is helpful. The Valsalva maneuver is performed by asking the patient to bear down or strain. This maneuver increases intrathoracic pressure and decreases venous return to the right heart. Most murmurs decrease during the strain phase of Valsalva. After release of the straining phase, right-sided events return in 1 to 3 beats, whereas left-sided events return in 4 to 11 beats. This is the most common maneuver used. Exercise increases the heart rate and thereby increases blood flow. Murmurs and sounds may be increased in intensity. Respiration also changes the loudness of sounds by bringing the heart closer to the chest wall and making the heart sounds louder. Therefore, faint diastolic murmurs of aortic or pulmonic regurgitation may be heard better during expiration. Hand grip, in which one hand is gripped with the other, causes an increase in peripheral vascular resistance, increased blood pressure, increased heart rate, and increased cardiac output. This maneuver increases left-sided regurgitant murmurs, such as aortic and mitral valve regurgitation, and VSD, ventricular septal defects, and decreases left-sided ejection murmurs, such as aortic stenosis. Besides the normal heart sounds, there are several other sounds that can be heard. I will be discussing murmurs rather extensively, while only mentioning the others in related sections. There are 4 heart sounds, S1, S2, S3, and S4. 2 heart sounds are audible with the stethoscope, which is S1 and S2, and they equal the lub and the dub. S3 and S4 are not audible with the stethoscope under normal conditions because they are very low frequency heart sounds. With pathology and a few select circumstances, they are sometimes heard with the stethoscope. The first heart sound. The tricuspid and mitral valves open to allow blood flow into the ventricles when the atria contract. This is diastole, and snap closed when the ventricles contract, which is systole, and this prevents blood from going backwards from the ventricles to the atria. The first heart sound is produced by events surrounding the closure of the mitral and tricuspid valves. The sounds are caused by vibrations set within the walls of the ventricles and major arteries during valve closure. It is heard best at the apex of the heart in the mitral area while using the diaphragm of the stethoscope. It occurs at the beginning of systole. It is nearly simultaneous with the carotid upstroke. S2 is produced due to events surrounding the closure of the semilunar valves, which are the aortic and the pulmonary valves. S2 is loudest at the aortic area and is heard best with the diaphragm. The normal physiologic split of S2 is heard on inspiration. It becomes single on expiration. During inspiration, there is a decrease in intrathoracic pressure that permits an increase in venous return to the right atrium. This increased blood in the right atrium prolongs right ventricular systole and delays pulmonic closing. Remember that during inspiration, the diaphragm lowers and the intercostal muscles pull up the chest up and out, which decreases intrathoracic pressure so air is drawn into the lungs. This is a common finding in younger adults. Now, a pathological split S2, so you have to determine whether the split is innocent or pathological. A pathologic split S2 is fixed and does not change with inspiration. A paradoxical split narrows or closes with inspiration, the opposite of a physiologic split S2 that we talked about on the previous slide. Systole occurs when the mitral and tricuspid valves close, the ventricles contract, and blood is ejected through the pulmonic and aortic valves to the lungs and the body. During diastole, blood flows passively from the atria into the ventricles through the mitral and tricuspid valves. Atrial contraction also occurs near the end of diastole, adding about 25% more blood to the ventricles. It's also called the atrial kick. This is a great schematic of the atriodiastole and systole compared to the ventricular diastole and systole. The length of ventricular diastole is greater than ventricular systole until the heart rate's about 120 beats per minute. Then they become equal. Now the third heart sound. An S3 usually means that ventricular compliance is subnormal. It's a strong indicator of early heart failure. According to Sapira, The Art and Science of Bedside Diagnosis, they use this quote, "It is the failing heart's way of saying, I have such a low ejection fraction that as soon as the added blood from the atrium even starts to fill me, it beats as a mallet against my tired, fatigued, completely non-compliant drumhead." Close quote. S3 is more likely to be heard with inspiration, after exercise, with tachycardia, elevation of the legs, and increased venous return. S3 may be normal in children and young adults. It's called physiologic S3, but will usually disappear if they sit or stand up. Okay, now we're going to talk about the fourth heart sound. S4 is called an atrial gallop because the atrial kick or contraction pushes the blood into the ventricle. It's heard just prior to S1. An S4 is due to blood rushing into a ventricle with decreased compliance. In this case, the ventricle was compliant enough to handle the blood that entered it in early diastole. as opposed to the S3 that is heard in early diastole because the ventricle is even less compliant. But with S4, the ventricle is not compliant enough to handle the additional blood that enters the ventricle in late diastole with the kick of the atria. It may occur with hypertension, MI, heart failure, coronary artery disease. It may be normal in children and athletes and is heard in many elderly persons. This is the most common extra heart sound. Here's a simple schematic of where you expect to hear the various sounds. Note where the S3 and S4 are located. Okay, now we're going to talk about heart murmurs. Laminar flow refers to streamlined movement of blood. In laminar flow, blood flows in layers which move parallel to the long axis of the blood vessel. So straight arrows are the parallel to the vessel long axis. Close to the vessel wall, an infinitely thin layer of blood in contact with the wall is stationary. It doesn't really flow. The next layer in contact with this layer has a low velocity. As the layers extend toward the vessel interior, their velocity increases. Velocity is highest for the layer at the center of the vessel lumen. Therefore, blood flow velocity is 0 for the layer in contact with the vessel wall and highest at the center of the vessel lumen. Blood flow in most vessels of the body is laminar. Despite the pulsatile nature of flow in arteries, laminar blood flow is silent. Thus, no sound is normally heard via a stethoscope placed over arteries. Constriction of the vessel or obstruction of the vessel lumen disrupts laminar flow and leads to turbulent blood flow. This is shown in the illustration by curved arrows and short straight arrows showing flow in directions other than along the long axis of the blood vessel. At the point of constriction, blood flow velocity increases, but small eddies lead to flow in directions other than parallel to the long axis of the vessel. Such current eddies lead to turbulence. Turbulent blood flow is noisy and can be heard by using a stethoscope placed over the artery at or distal to the point of constriction or obstruction. And by the way, an eddy is the swirling of a fluid and the reverse current created when the fluid is in a turbulent flow regime. When blood is forced through stenotic valve, it produces an abnormal whistling sound, and when it flows backward through incompetent valve, it produces a swishing or gurgling murmur sound. The most common cause of stenosis and incompetent valve is rheumatic fever, an autoimmune disease triggered by streptococcal bacterial infection. To identify a murmur, you need to consider the 6 characteristics of location, loudness, pitch, quality, timing, and radiation. In addition, for systolic murmurs, you need to consider where in systole that the murmur falls and its sound pattern. The loudness of murmurs is graded from 1 to 6. It takes practice to recognize murmurs. I think I probably can identify grade 3 and higher. I'm sure that those of you who work in cardiac can identify at least a grade 2, if not a grade 1. Generally, the quality of sounds are classified as blowing, harsh, rough, or a rumble. Higher pitched sounds are best heard with the diaphragm, while lower pitched sounds are best heard with the bell. In my practice, I most often run into aortic stenosis because of its prevalence due to calcification of the valve in the aging process. The three causes of systolic murmurs can be aortic stenosis, mitral regurgitation, or ventricular septal defect. Systolic murmurs may be physiologic also. Margaret Fitzgerald uses this mnemonic to remember valvular causes of systolic murmurs. She did not include VSDs. So Mr. Pass also wins the MVP award. Mitral valve prolapse is one type of mitral regurgitation. Systolic murmurs can be benign or pathologic. Other terms for benign would be physiologic or functional. To be considered benign, all of the items listed must be present. The murmur might soften or disappear with position change from supine to standing, and that's because while the patient's lying down, the heart is more filled with blood than when standing. The additional volume in the heart may increase the intensity of the murmur when lying down. A systolic murmur may be pathological if one or more of the items listed on the right-hand side are present. In mitral regurgitation, the mitral valve is incompetent and does not close properly. This results in abnormal leaking of blood from the left ventricle through the mitral valve and into the left atrium. Mitral regurgitation is usually progressive and may result in heart failure over time. Note that it has a holosystolic blowing. That means that the blowing sound lasts throughout systole, and it often radiates to the axilla. Primary refers to an abnormality of the valve itself. It is often seen with infectious endocarditis, connective tissue disorders, radiation cardiac disease, rheumatic heart disease, or progressive mitral valve prolapse. Functional mitral valve regurgitation is usually caused by a damaged left ventricle, and the common causes are coronary artery disease or myocardial infarction, which causes deformation of a normal valve. Mitral valve regurgitation symptoms. Symptoms develop from the heart failure that ensues with chronic regurgitation. At the bottom of the slide is a schematic of the heart in a linear format. I've drawn a line at the mitral valve that divides the left atrium and left ventricle. During systole, in mitral regurgitation, some blood goes backwards into the left atrium. The symptoms are dependent upon the degree of regurgitation. As blood backs up into the left atrium, it increases left atrial pressure. That pressure, therefore, backs up into the pulmonary vein, the lungs, and into the right heart. The majority of symptoms are related to congestion in the lungs. That increased in right atrial pressure may cause atrial fibrillation. In atrial fibrillation, the atrium do not empty completely and blood stagnates, potentially leading to the thrombosis and embolization. What might you find on mitral regurgitation upon physical exam? Well, the apex of the heart is hyperdynamic. The sound may be laterally displaced because of left ventricular hypertrophy. An audible S3 is present when there is hemodynamically significant mitral regurgitation. There may be a palpable S3 with a thrill and even a peristernal lift secondary to the left atrial distension. The hallmark of mitral regurgitation is the hollow systolic murmur that usually radiates from the apex to the axilla. Mitral valve prolapse is a subset of mitral regurgitation. Mitral valve prolapse results from the failure of apposition or coaptation of the anterior and posterior mitral valve leaflets. During systole, there is a mid-systolic click with a late systolic murmur. Mitral regurgitation will occur if it is severe. Mitral valve prolapse is relatively common. It affects females in adolescence and young adulthood more often than males. I do not have any male patients with mitral valve prolapse. There seems to be a strong hereditary component. If you question the patient, his or her mother also has the disorder. It is also associated with pectus excavatum and thoracic disorders such as scoliosis. The majority of patients with mitral valve prolapse are asymptomatic. If they do have symptoms, it almost always is palpitations accompanied by dyspnea, fatigue, and anxiety. The palpitations are usually caused from premature ventricular contractions or paroxysmal supraventricular tachycardia. The heart rate may be fast enough that they may have syncopal episodes, but this is unusual. They often feel faint and want to lie down during the palpitations. Most cases of mitral valve prolapse are diagnosed on routine physical examination. Auscultation of the patient with MVP reveals a mid-systolic click. There is a snapping extra heart sound heard best at the lower left sternal border or at the apex, and it may be only intermittently appreciated. The presence of an apical systolic murmur varies with the degree of mitral regurgitation. This systolic murmur is usually a late systolic crescendo type that can be loud and musical. Maneuvers that decrease the left ventricular volume, such as standing, will both move the click earlier in systole and make the murmur longer. In aortic stenosis, the aortic valve narrows. This causes the left ventricle to work harder to create enough pressure to move the blood forward through the valve. If the patient is young, think congenital. A bicuspid aortic valve occurs in approximately 2% of the population with a 3-to-1 ratio of male to females. Be aware, because there may be coexistent coarctation of the aorta in about 6% of those patients. If the patient is middle-aged, in the 4th and 5th decade of life, think bicuspid or rheumatic disease. If the patient's in their 6th, 7th, or 8th decade of life, think degenerative causes due to calcification of the valve. Aortic stenosis has some cardinal symptoms. The coronary arteries begin at the base of the aorta directly above the aortic valve. Because of the stenosis, there is reduced blood flow into the aorta and into the coronary arteries. In addition, the workload of the heart increases, which in turn increases oxygen demand. Syncope occurs especially with exertion, as the cardiac output is relatively fixed. The heart cannot meet the additional forward blood flow that is needed during exertion. This may result in syncope. Chest pain and syncope can occur without left ventricular dysfunction. Dyspnea is usually a sign of heart failure and left ventricular dysfunction. No physical finding can reliably assess the severity of aortic stenosis. The intensity of the murmur and the presence of a thrill does not predict severity. The murmur with aortic stenosis is a harsh grade 2 to 4 systolic murmur with a crescendo decrescendo pattern. There is a decreased delay and prolongation of the pulse amplitude. A thrill is present at the bilateral upper sternal borders. Paradoxical splitting of the second heart sound, S2, occurs as a result of delay and closure of the aortic valve. Left ventricular hypertrophy produces a sustained thrust or heave of the apical impulse. Displacement of the apical impulse downward and to the left occurs after left ventricular failure develops and the ventricle dilates. S3 and S4 may be present in ventricular dysfunction. Please note on here that this sound radiates to the carotids or towards the neck. For ventricular septal defect, it's a congenital opening in the septum between the ventricles. Because the left heart pressures are greater than the right heart during systole, the blood in the left heart goes across the defect into the right side. This produces a holosystolic murmur that can be heard over the sternal border. Diastolic murmurs are almost always pathological. They occur right after S2 and before S1. They can be classified as early diastolic, mid-diastolic, or late diastolic. The two most common causes are mitral stenosis and aortic regurgitation. Margaret Fitzgerald uses the mnemonic Miss Ard. In aortic regurgitation, the aortic valve does not close fully. During diastole, some of the blood in the aorta fills backwards into the heart. There are numerous causes of aortic regurgitation. The most common would be degenerative causes related to aging. I highlighted two of the other common causes. Patients with chronic aortic regurgitation may be asymptomatic for decades. When symptoms do occur, the patient usually reports symptoms of heart failure, especially dyspnea and fatigue. Patients may also have angina in the absence of significant coronary artery disease. Patients with acute aortic regurgitations may have symptoms of severe left-sided heart failure, which would be dyspnea at rest, orthopnea, paroxysmal nocturnal dyspnea, fatigue, exhaustion, and they may appear suddenly. Symptoms of low forward cardiac output, such as fatigue and exhaustion, are overshadowed by symptoms of pulmonary congestion in patients with acute aortic regurgitation. In aortic regurgitation, the blood in the aorta falls back into the heart during diastole. This reduces the diastolic pressure and causes a widened pulse pressure. The sound is rather loud, high-pitched, blowing, decrescendo diastolic murmur that is heard best at the lower left sternal border. Mitral stenosis is caused by narrowing of the mitral valve, resulting in less blood being able to flow from the left atrium into the left ventricle. Pressure increases in the left atrium, which eventually is reflected in the lungs, right heart, and the periphery. In addition, there is poor forward blood flow, reducing cardiac output. Mitral stenosis is almost exclusively caused by rheumatic fever. 2/3 of the patients with mitral stenosis are female. The signs and symptoms of mitral stenosis results from the backup of blood behind the mitral valve. With mitral stenosis, there may be a palpable S1 at the apex along with a palpable opening snap. There is an opening snap after the aortic valve closure when the mitral valve opens. This is followed by a low-pitched diastolic rumble at the apex of the heart that is heard best with the bell of the stethoscope. The EKG changes are changes due to atrial enlargement and retrograde pressure changes. Here is FP, an 84-year-old female. She presents with a chief complaint of, "I get dizzy while vacuuming or walking up the stairs." She denies chest pain but admits to dyspnea upon exertion. Her symptoms disappear rapidly upon rest. Her blood pressure is 112/88, grade 2 harsh systolic murmur with radiation to the neck, loudest at the upper sternal border. She has no S3 or S4 and no jugular vein distension. Her clinical presentation is most consistent with which diagnosis? The answer is number 4. Now, mitral stenosis is incorrect because it produces a diastolic murmur. Aortic dissection would be an emergency with multiple other symptoms. Systolic heart disease is too general. So this FP, this patient has a narrow pulse pressure, a systolic murmur with radiation to the neck. Again, note the radiation that is loudest at the upper sternal border, and she's 82 years of age. She probably has a calcific aortic stenosis. Okay, here's MP, a 62-year-old male with hypertension and heart failure. He's here today for a follow-up. His PMI is at the 6th intercostal space with a sustained impulse. He has a grade 3 blowing holosystolic murmur with radiation to the axilla. The murmurs accentuated in the left lateral decubitus position, softens with position change from supine to standing, and louder with hand grip. The S2 is not heard. So these findings are most consistent with which problem? And the answer again is number 4. He has a holosystolic murmur with radiation to the axilla, plus several other indicators. Thank you for your time. Please go to the websites provided and review the heart sounds.